Ladies and gentlemen, welcome. It's 1:59, but I think we can start a minute early. And Dr. Manis has graciously given us his time, which is extremely valuable. And after you listen to him for a few minutes, you'll understand why. But I must tell you that when I went through my prostate cancer journey, I was looking at virtually every doctor under the sun that I could find to help me. And largely urologists and radiation oncologists, various other treatment source doctors, and so on. But I was on watchful waiting by my own choice, as well as the choice of many of the doctors I spoke to, who said, yes, you can try that for a while. And so I figured what I needed most was somebody to really keep an eye on what I was doing. And Dr. Manis came to my attention as an oncologist and a hematologist. I thought, the study of blood is what really controls a lot of what we're going through. And he was tremendous, I have to say. He's the most responsive doctor I've met in many, many years. And on top of that, the most knowledgeable about all kinds of different options that are available and how you deal with cancer and disease in general. So that's my little introduction. I could tell you about his background, but more importantly, I think, is his presence right here. And thank you, Dr. Manis, for joining us.
Well, thank you. So just tell you a little bit about myself. I've been here in Sarasota for 14 years. Prior to this, I was in Orlando for 21 years. I was chief of medical oncology at MD Anderson Cancer Center Orlando. I've been seeing patients since 1980. I have, I think, the second or third largest practice in the state. So I think for our discussion today, it's like my point of view. I spoke at this conference like 5, 6, 7 years ago. And at that time, my approach philosophically and looking at the big picture, I think was very different than many. And I think after sitting over this weekend and thinking a little bit about this, I think that my feelings about going away from the mainstream are even more. So to start, just out of interest, anybody in the crowd here have a nephew or a grandson aged 20 to 30? Anybody in the crowd? How many do we have here? Let's say we've got 10. Do you know the chances are 1 out of 10 that one of you have a grandson or a nephew or whatever that's prostate cancer? Have you ever heard of anybody less than 30 years old getting prostate cancer that you can think of in your experience? No. Okay, well, that's the numbers, okay? I'm telling you the numbers 10%. Between high-grade prostate, non-invasive prostate cancer. Now, who in the room might know people that are 20 to, let's go to the next, say 30 to 40 years old? Males, 30 to 40 years old. We have a couple people here? Yeah. Okay, so if you have somebody 30 to 40 years old, and let's say we have 10 hands here, the chances are 2 out of 10, 1 out of 5, that there's prostate cancer. So how many people here have seen somebody treated or diagnosed or have a problem with prostate cancer before the age of 40?
Below age 40?
So like, well, what's happening here then? I mean, I'm telling you, these are numbers from autopsy series. We have on age 30 or less, 10% prostate cancer. Age 30 to 40. 20%. So how is this that we are basically faced with this and nobody's seen this? Any ideas?
Haven't been tested.
No. Well, they can be tested. Let's think about this. And particularly in the Sarasota community, it's God forbid that there's a prostate cancer missed in somebody 90 years old. Okay. So let's think about this. They're 20 years old. They're 30 years old. And there's a significant number of prostate cancer that people have. Why are they not dying? I mean, aren't you told if you have a diagnosis of prostate cancer that if you're not treated 2 days before your diagnosis, you could die? I'm serious. Let's think about this. I heard of something 2 years ago. A 91-year-old patient was suing for delayed diagnosis of prostate cancer. Seriously? Okay. So as a medical oncologist, I don't give radiation. I don't do surgery. When my father was alive, he was diagnosed with prostate cancer at age 74. And he had a lot of other problems, a lot of cardiovascular disease, probably about 10 heart attacks, et cetera, et cetera. Of course, he went to a urologist who told him what? You need to have your prostate taken out. So he came to me, said, what should I do? I said, you should do nothing. And his response was that he sent the kid to Harvard, went to Syracuse Medical School, and obviously stupid, didn't learn anything. Okay? So then he said, okay, I think you shouldn't do anything. The surgeon thinks you should have your prostate out like last week. Let's get a third opinion. So let's send you to a radiation doctor. So I sent him to one of my friends, and the only instruction I gave him was that my dad is coming, tell him he needs nothing. Okay? And so he died about 3 or 4 years later with heart disease. Prostate cancer never bothered him. Okay? Now what about, I think there's a couple of people in the room here, looks like a little bit older than 30 or 40 years old. What's the chance of having prostate cancer, either invasive or non-invasive prostate cancer, over the age of 70? 70? Over the age of 70, what's the chance of having invasive or non-invasive prostate cancer over the age of 70? 80%.
Yeah.
So, does that mean that basically 4 out of 5 men in this country who basically are into, or just died, that are basically into Medicare age, that they are basically, do you know 4 out of 5 people of age over age 70 who are being treated for prostate cancer? I don't know that. Okay. The point I'm trying to make, with all this, trying to make the point is that prostate cancer biologically is very heterogeneous. There are many people who have prostate cancer where, this whole issue, which was discussed a little bit earlier, alluded to, about watchful waiting, whether intervening, and et cetera. So the point I'm trying to make before we get into what I consider much of this discussion is that my view is very different than radiation oncologists or urologists in many cases. And I think it's more philosophical, and I think what I like to do is deal with reality. I use the word pragmatic. In terms of prostate cancer, the numbers I'm telling you are from autopsy series, and these are multiple autopsy series. The biggest one from Wayne State. These are real numbers. So the prevalence, the amount of disease actually present, is huge. Probably 80 to 90% of the prostate cancer at a given age is never diagnosed before death. So that should give you some pause. If I'm telling you that you've got a 5% chance of having prostate cancer under age 30 and going over age 40 to going to 15 to 20%, don't you think, based on probably much of what, and again, I don't know the history of anybody in here, but it should give you some pause that these younger people have prostate cancer which are not being detected and they're not being treated. Now, I don't know that in many cases that when people are going to see a urologist, either diagnosed with prostate cancer or seeing a radiation oncologist, that there's a big push to say, well, maybe we don't need to do anything right this second, okay? And so I'm just sort of being a little bit provocative here and trying to say that, for people that are flipping out or basically they're, for example, one of the common questions I get, should I have radiation? Should I have external beam? Should I have implant? Should I have HIFU? It doesn't matter as far as I'm concerned, okay? The bottom line that I think with prostate cancer, I think there's basically 2 realities. And the 2 realities are is that there are probably 85% of men with prostate cancer that no matter what you do or don't do, they're going to do okay. 10 to 15% of patients, I would say maybe in the range of 10%, have really bad prostate cancer. And no matter what you do, the patient ultimately is not going to do well. And this is borne out by, I think, the mortality rate, roughly 10% from prostate cancer. Very common, prevalence 21%, by the time people are 80 years old, diagnosed clinically. And so what I'm trying to sort of talk about here is that a shift away, for example, I just looked over this weekend briefly, new potential treatments for prostate cancer. And my personal feeling after looking at everything is much ado about nothing. All the local therapies, I don't honestly think that for many patients, whether you do external beam radiation, with or without an implant, depending on the size of the tumor, et cetera, or surgery, I just don't think it makes a great deal of difference. And your destiny to do well or not do well. Now the question then is, well, how can you figure out if you're not going to do well? What do I mean by that? What I mean by that, I'll give you a patient in my office that comes to mind. I had a patient with supposedly relatively safe prostate cancer. At least the score was like 5. PSA was like maybe 8 or 9. This was probably about 4 years ago. So the fellow's got a lot of problems. He's got heart disease, a lot of risk for having surgery, so decided to do radiation therapy. So he gets radiation therapy, and his PSA prior to radiation, I think, was like 8. So it would drop down to maybe like 3 or 2 or something during radiation. And about 6 weeks after radiation was done, it was up to 20. Okay. So, and again, the patient was told, well, before the treatment, you should do just fine, you're gonna live to be 1 million years old, and da, 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 da. By the way, you have no side effects. It's gonna cost nothing. This is typical nonsense. And so what I'm sort of saying here is that, to me, it just becomes rather, so a couple of realities. Reality number one is that when people are trying to tell you what your prognosis is, particularly prostate cancer, I think it is a bit of a shot in the dark. And there are 10, 15, 20 different tests that you can do to try to figure out based on gene mutations, what your Gleason score is, what your PSA doubling time is, blah, 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 blah. And not only for prostate cancer, but for many tumors. I tell this to my patients all the time. Last time I checked, the tumors do not read the textbooks, okay? And so you can have things where you suspect that the patient's going to do just fine, and all sorts of problems. And so I think that what I'm sort of saying here is, I think philosophically, a couple of things to think about. I think before you start talking about the different types of treatment, I think you first should need to think a little bit about what it is that you're doing. I mentioned the issue with my father. He had 10 heart attacks. The chances were he was going to die from that or stroke. He had prostate cancer. In our family, he was, I think, the only person out of about 200 people with cancer. Everybody else had heart disease. Okay? So my personal feeling, I should just mention the fact, up to this point, I'm 66 years old. I've never done a PSA myself, and I don't plan to. Okay. Current recommendations from the federal government going back a number of years is not to just screen PSAs. You're supposed to, if you're allowed to do a PSA if your physician or patient wants it, that's fine. But in terms of recommendations from the National Task Force, recommendation a number of years ago was not to do screening PSAs, to do PSAs only in patients who are diagnosed with prostate cancer. So before we go on, let's just spend a second on that. What's that all about? God forbid you should have your PSA before your Social Security number, okay? And what this sort of gets down to is that the reason this recommendation was made was because when you look at the studies that were done for people that had, and I'll tell you exactly one of the studies that sort of made the determination. It was a study done at the VA hospitals and the Center at the University of Minnesota, where I actually did my fellowship. And the study that they did was that it was a randomized study. Persons diagnosed with prostate cancer, they either have nothing done or they have a radical prostatectomy. And then I think by 8 years, the survival was the same. Actually, the first 2 years, the people who had radical prostatectomies, the survival was worse. Any idea why it was worse the first 2 years?
Too much invasion.
Because people died from their surgery. So they died from their surgery, and statistically, they could not show a benefit of survival at 8 years. Now, is that a shock? No. I mean, 90% of men who have prostate cancer are not going to die from it. So if you're trying to show a difference between two different treatments, treatment versus observation, you have to have, one of the shortcomings of the study, had a couple thousand patients on it, is that they probably to prove any difference, they probably have a much larger study, 10,000 people. If you're doing a clinical study, if there are small differences between treatment A and treatment B, the smaller the differences, the more difficult it is to prove a statistical difference. So going onward is just sort of general comments. If somebody has prostate cancer, I think if you look at the patient, typically the patient's going to be older, and you have to try to get some sense as to how dangerous you might think the prostate cancer is. I think for Gleason scores about 5 are high risk. If you have a PSA doubling time, the shorter the worse. If you have a PSA doubling time under 90 days, that's not good. And those are simple-minded ways of trying to approximate what's going on. And as I said, approximation, because sometimes you're fooled. Sometimes, I'll give you an example. I had a patient here 14 years ago in Bradenton who I saw who had PSA was 1,400 presentation. Prostate cancer, metastatic to bone. He is still a patient right now. His most recent PSA, I think, was like 2 or something. This fellow we treated for about 2 years. Again, you think about that. PSA of over 1,000, bone mets. That person's not home for this world. I was treating a guy for about 2 years. PSA went down to nothing. Bone scan became nothing. And then when I went on vacation, he came into the office and said, well, when we were on vacation, I saw the radiation doctor and he wanted to radiate my prostate. And he said, I wouldn't do it unless I talked to you first. And I said, why would you possibly radiate the prostate? In other words, if you're going to give, he's asymptomatic, it's not going to cure you. In other words, if you think about it, if it's gone to 20 bones, which have disappeared because of medical treatment, or even discontinued medical treatment, giving radiation to the prostate is completely irrational. It makes absolutely no sense. And so what I'm sort of pointing out with these cases is that I gave you one case where the PSA was like 8. And the patient was in trouble like 6 weeks after radiation. I gave you another example of a guy with PSA over 1,000, who's not only still alive, his PSA is less than 10 right now. And he's only had second-line hormonal therapy. He also, by the way, the guy with the PSA over 1,000, we actually gave him a break for, it was like a long story, for about 2 years we had nothing. Okay, so it's really very, very okay. Also, the other thing is, as you're thinking about all these things, I mentioned the study where they did a VA study where they compared observation versus radical prostatectomy. And I told you that the first 2 years, the outcomes were worse, survival was worse on the surgical arm because there were people who had surgical complications and died. And so I think through all this is kind of the thoughts I have, is in addition to having some clue as to how aggressive the prostate cancer is, there's many, many things you can look at. The things I look at are Gleason score, the PSA doubling times, is there metastatic disease? And then what happens is that many of the patients that we have prostate cancer, it's not occurring in a vacuum. They've got, it's just heart failure, they have 3 strokes, they've had this, they've had that. So you have to sort of try to come to some sort of a feeling as to whether or not the patient needs treatment at that time and what's best. Now, what I would just say to spare everybody in the audience this is that for people that want to basically say, well, I'm going to do HIFU, or I'm going to do radiation, or I'm going to do surgery, all of them have their issues. As far as I'm concerned, HIFU has a decent amount of information, but basically, as far as one can tell, the outcomes are relatively similar. The side effects, in many cases, are relatively simple. What I would also say, as we're talking about, especially with new modalities, there's often an assertion that some new treatment is 100% wonderful, has no side effects. Okay. When HIFU first came out, I can't remember, it was not being, and I'm not sure even now if it's being paid by insurance, but it was not being paid for insurance. So I had a patient who had a PhD who made probably 7 visits to my office to figure out whether she should do radiation or HIFU or this or that. And he was told by his radiation therapist, or actually his neurologist, we can do this, no problem, blah, blah, blah. And so this was a protracted discussion. This guy read 14,000 papers, and et cetera. So, of course, what happens? He gets it done. He has urinary incontinence. He has multiple complications, is having, peeing randomly, not being able to control anything. And his PSA starts going down. Okay? So I can't tell you the number of times that I've seen patients where, yes, this is going to work fantastic. You're not having any problems. You're going to be cured forever. And the problem is that once the patient relapses, they never go back to the person who treated them. Okay, so this is my world. I think from a bigger point of view, the problems that I would identify for prostate cancer are the following. I think that, first of all, the local treatments, I think, are unsatisfactory for a number of reasons, whether it be radiation or whether it be surgery. I think the things that are unacceptable is that at this point we are not terribly great at predicting what the outcome is going to be after one of these procedures. So what I'm trying to say here is that if you had a treatment that would cause sexual impotence, that could cause urinary incontinence, and you knew that in 6 months after you did the treatment, did you get back to square one because your PSA is going back up? That's not a good look at the world. And so what I'm trying to say here is that perhaps more than many types of treatments for cancer, the attempt at local control, as far as I'm concerned, is less than satisfactory because it's not as good as it should be. And number 2, the consequence to the individual, even if you're cured, if you're left and you can't pee, you've got to basically self-catheterize or something for the rest of your life. In terms of quality of life, it's a huge downside to this. That's one issue. The second issue is that it seems to me that when we are talking about, like when I look this stuff up, and it gets redundantly boring to look at this. We have now 5, 6, 7 different hormonal therapies towards prostate cancer. We've had several in the last, I think, 2 or 3 here in the last year. have they fundamentally changed the playing field for patients with advanced prostate cancer? Absolutely not. With regard to chemotherapy, the same story. Nothing has changed dramatically in a number of years. I think what is a glaring issue, it seems to me, is that I think many in the crowd here may have seen a lot of commercials on television for, like, for example, a drug like Keytruda. There have been like innumerable commercials on TV for treating lung cancer with immunotherapy.
of comfort level, if you want.
I think that's a general truth. Again, I'm not trying to tell people here that you should get treated for prostate cancer, but as I said, I think you have to take a long pause and just think about exactly what it is you're doing and why you're doing it. It should not be done in a vacuum. So in other words, it has to, for many, if not most of the patients with prostate cancer, they've got other things going on, especially if they're in 70s and 80s, and you have to, the initial thought is not to harm somebody, and so I think the question is, what do we have? Is it something that really does need treatment right now? Is it something that we can wait on? And what I'm saying is that even if you have somebody who's 75 years old and an Olympic athlete, there's still things. I mean, it would be very nice to have a treatment which did not have such a, in my view, such an adverse effect on the quality of life, and that for that payment, in other words, I think, you talk about really difficult situations. If somebody has, let's say they had surgery, let's make that radiation. Let's say they had radiation and they got the treatment and then they ended up getting complications, urinary incontinence, can't control the urine. And on top of it, there's blood in the urine because they got radiation cystitis. And on top of that, every time they go to the bathroom, a bowel movement occurs and they have blood because of radiation bronchitis. And then throw on top of that rosy picture a recurrence 3 months after you did, or a year after you did. I mean, it's devastating. I think that it is not, from my point of view, it is not satisfactory. We should be able to do better than this. And the current primary approach to prostate cancer, I may be talking with this 5 or 10 years down the line, even longer, but it would be very nice to be able to have some sort of a situation where there would be much less adverse effects on everyday things that one needs to do. A better idea of actually how dangerous was it to where, could we have a little bit better idea of who we can actually sit on and wait on others?
As a corollary, I think you're also saying science is finally speeding up in the direction of immunotherapy.
Right.
So you could say that a new patient will have 6 or 8 could afford to wait off 2 or 3 years with somebody very
If somebody's got a Gleason 8 or something, you cannot wait 3 years. That's going to explode. I mean, that's not okay. Let me put it this way. For people who have prostate cancer right now, this is not going to probably an immediate effect in, say, this next 24 months. And so I'm sort of looking over the horizon. And what I'm sort of saying as a medical oncologist is that whether in many cases when you do radiation, variation radiation, or surgery for primary prostate cancer that's, Gleason 5 or something, okay, PSA is like 10 or whatever, and you're going to do something, I personally don't believe it makes one bit of difference which one you do in terms of local control. I think it's just a question of what side effects you want to look at. So oftentimes discussion on the side effects. But as I said, what I think going forward is that, again, this is not ready for prime time, although immunotherapy has been out now almost 4 years. The stuff that we have right now, at least so far, has not been demonstrated to have a lot of activity in prostate.
A couple quick questions. First of all, how do you know if someone has prostate?
No.
No PSAs, right?
Well, let's just backtrack.
You don't.
Some others like,
So,
I meant, let's go backwards. What I said earlier, under the age of 30, it's like 5 or 10% of people have prostate cancer. And somehow they manage to go through. Again, I haven't seen anybody treated for prostate cancer less than, with the exception of the one patient I just mentioned, who has a prior 2, I haven't seen anybody with prostate cancer under the age of 45 in the last 14 years. Now, again, I'm not a urologist, but I've seen the patients.
but how do you know? How do you know it all ever?
Well, let's think about this. Maybe something like, I think the number is that I think 21% of men by age 80 potentially can be found with prostate cancer. That's still 21%, but the number actually having an autopsy series is 80%. So what I'm saying is, even when you're looking, three-fourths of the case are missed. So the only way you did prostate cancer is basically, you can do PSA, you can do, I think rather than the physical examination, I think a multi-parametric MRI of the prostate will give you a pretty good idea what's going on.
But why would you do that?
What I'm saying to you is I wouldn't, I haven't done it myself, I haven't done the liver, I haven't done the MRI.
So you're not really finding out until someone has got the spreading of the prostate cancer and the dying.
Not necessarily. I mean, sometimes basically it's not by accident. I mean, what happens is people can't urinate, change urinary habits, make blood in the urine, and a number of different things. So the idea I'm trying to say here is that even when you find it, let's say you did a PSA on every single patient that walked in the door. What I'm telling you, over the age of 80, 3 or 4 patients, even when you do that, you're still missing it. And when I'm saying these numbers from autopsies, people just die from
No,
whatever.
I understand that.
Yeah.
Someone 65 and they're healthy.
Yeah.
And they have a very serious expanding prostate cancer.
Mhm.
And you don't test for it. You just wait until it's metastasized all over, right? There.
Well, let's just go backwards. Of all the men, let's ask the question a different way. Let's use your approach here. You do PSAs on everybody.
No. You were not doing any PSAs. I'm wondering.
There's no survival benefit. I'm just telling you. So what I'm telling you is that if you have advanced prostate cancer, I already said earlier, 90% of men are not going to die from prostate cancer, irrespective of the stage. 10% will die because of bad tumor. And what, to take it one step further, is the reason this recommendation came down from the federal government is, give me a second, is because when you look at a whole population, you could not demonstrate presence.
No, I'm not complaining about
Yeah,
this.
okay.
I'm just saying, you're talking about this fellow that had a Gleason of 8 or 9 and
Mhm.
would explode. You would never know that.
That's right.
Period.
That's right. But let's turn it around. Let's say you did know, then what?
How would you know?
Well, so the point I'm trying to make, even if you did know,
Well, isn't it?
what I'm trying to tell you, if you listen a second, the outcome, I'm trying to tell you, if you have at least 8 or 9, and those are very dangerous tumors. So until you develop some symptom, what I'm trying, even if you had a symptom with an advanced prostate cancer, what I'm trying to say with this is that even if you intervene before or after, what I'm trying to tell you is it didn't make any difference. This is the whole argument having to do with the recommendation of the federal government not to do it, because.
I understand.
But what are the?
So I guess the question was like, okay,
So you're recommending no surgery or radiation on anybody anytime?
no, I didn't say that whatsoever. I'm just telling you, no, that's not what I said. What I said, no, well, what I'm saying is what I'm saying to you is that you can do, to backtrack a little bit, is what I'm saying is that in terms of the options, okay, you can do radiation or surgery, you decide what you want to do. But what I am telling you, and from my point of view, is that 90% of this is probably preordained. And what I'm just telling you is from what I see in my office, is whether you're seeing, if you have a Gleason 8 who just got treated with radiation and 3 months later his PSA is going up, do you really think that that's much different if you walked in with somebody who had Gleason 8 that you didn't know about and has bone metastasis? Do you think let me finish. Do you think the outcomes are going to be different? They're not.
I'm not talking about Gleason 8, I'm talking about someone who maybe before that.
And
The
so,
way Gleason 8, but not.
so an individual person, if you're not looking, you're not going to know. Okay, but the point is that what I'm trying to say is that the bigger picture is you don't know whether you know or not. Is the question, does it make a difference in survival? Doesn't appear to be the case. Yeah. So.
Any other questions? Yeah, Dave.
No radiation, nothing, no message.
It depends, let's look a little further. Everybody, this is an important point. In terms of doing this, I think everybody can make sort of their own decision. Okay, and all I'm just trying to point out is that in many, if not most of the conversations I have with people, they come in with, 14 papers they looked at and they're gonna do this and they're gonna halt the brains and blah, 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 blah. And what I'm saying is a lot more simple than that. I think what I'm trying to say here is that there are a number of patients who have relatively low-grade tumors that you can potentially heal. And I think if you take somebody with a low-grade tumor, my opinion is that even if, let's go back to my patient with the PSA of 1400. He's now out 12 years. So the question is, if he had been diagnosed not 14 years ago, but 16 years ago, would it have made any difference? I don't think so. Okay. And what I'm also saying is that when you have a high grade, talking Gleason's 8, 7, 8, something like that, these are dangerous tumors. Okay. And so, well, what I'm saying is that even if you do, you have the concept that even if you do something, that 10% of patients are going to die no matter what you do. So it's another way of saying, in other words, not to be completely fatalistic about it, but this is the reality. And this conversation is exactly what I had last time I was here. What I'm saying to you is that, and this is reality, is I think that 90% of men with prostate cancer no matter what you do or don't do, they're not gonna die from the prostate cancer. About 10%, you have at least an 8 with, a PSA doubling time of 30 days, that's a bad tumor. And so to think that, I see patients who say, well, I'm gonna do surgery and life is fine after that. No, it's not. I mean, most of those patients are gonna relapse early. And so going back even further, right, the first thing I said when I walked in here is that, supposedly under the age of 35 or 10% of patients have got prostate cancer. Well, the thing is that looking at your point of view, they don't know it. And no one found out an autopsy. I have not seen anybody in Sarasota with 25 years of prostate cancer. So the question is, if this was so terribly bad, why didn't they die? And in other words, how could they walk around for decades and not even know anything was going on? I'm just saying is that with regard to this, you have to look at the big picture. And what I'm sort of telling you on this big picture is that the stuff that you are going through in terms of quality of life, I think you have to think carefully about whether you want to do something, okay? And when you want to intervene. This is an individual decision which requires a bunch of different things. And again, it's not just simply the prostate cancer characteristics myself, but also what else is going on with the person.
And Dave has a question.
If a patient is treated with radiation or surgery and then they still have a rising PSA and they're put on hormone therapy, using what you said before about the cancer needs a blood supply and it has to be, and it's sort of camouflaged. Well, what is the hormone therapy doing? Because the PSA goes down to 0.
Well, basically what's happening is it's very similar to for prostate cancer. So basically you have a tumor that at least initially has got androgen receptors that respond to manipulation. So, and depending on the patient's tumor, like, so for example, let's go back to our 14-year patient with the initial PSA of over 1,000. Well, for some reason, he, for a protracted period of time, like over 12 years of treatment, he has never developed a cancer which is resistant to the idea of removing male hormone. So let's put this simpler. If you have a prostate cancer cell, typically those tumors have androgen receptors. They typically have this part of their growth dictated by the presence of male hormone. So when you remove the male hormone, the tumor shrinks. The problem is that in a number of these patients, is that what happens is that after you, for X period of time, you're getting like an injection. So something that, the typical thing that's of hormone manipulation usually an injection to decrease your testosterone to like basically 1% of normal, or almost close to 0. And when that happens, the tumor will stop growing. It will stop growing for as long as that tumor is dependent on male hormone as a fertilizer, if you will. The problem is that many patients develop tumors which become, what you use the term castrate resistant, which usually refers to somebody who's had an injection, which is pituitary agonist like Lupron or Eligard, and oftentimes we usually, give somebody for a first pill Casodex or enzalutamide. When you start adding a second, third, or fourth agent, what you're having is a situation where the tumor, at least in part, is not wholly dependent on male hormone being present, and then it gets worse. So what can happen is you actually, by giving the injections with the pituitary agonist, about 70-80% of patients ultimately develop a situation where they will not respond to either so-called enzalutamide or Zytiga. These are usually second, third, fourth line hormonal therapy. So effectively what happens is at some point, you start with a cancer which is dependent on fertilizer, which is male hormone, and then all of a sudden it says, well, I don't care about that, I can grow without it, and it becomes energy independent. And they use the term castrate resistant, which means that despite having a very low level of male hormone, the tumor is still growing. And those are the patients oftentimes end up on things like chemotherapy.
You talked about recurrence, and I'm really confused. If you have a prostatectomy or radiation, why would you have a recurrence? Are you talking about distant sites?
No, 95% of the recurrences, if after doing definitive therapy with either surgery or radiation, I would say 95 to 99% of the time, the first thing you're going to see is elevating PSA. So basically, you're going to have an elevating PSA with negative scans. Okay, so you can do any scan you want, every scan is negative. And so what it's felt to be, a local recurrence that you cannot see in imaging, being detected by PSA. And so this is not the exception, this is the overwhelming rule, is that you'll see an increase in PSA. If you get an increase in PSA, that means you have recurrent disease. It's typically local, and you can do CAT scans, MRIs, whatever you want, PET scans, you won't find it initially.
So recurrence does not mean necessarily that it's metastasized.
No, okay, so this is what the implications are, is that if you have a chemical recurrence, which means the PSA is going up, that means the prostate cancer is not being cured, A. B, it's not going to be cured. You have recurrent disease. C, if you have, as I said, one of the patients where 90% of the patients are going to survive is the majority of patients who have this, are going to respond to hormonal therapy, not all, okay? And the problems that you get into is that when you start getting a situation where you have to go beyond one hormonal therapy, then you get into all kinds of problems, okay? And so ultimately what happens is after the recurrence is that, let me put it this way. If you have a recurrence 3 months after you finish radiation or 15 years after you have a recurrence, does anybody have a clue as to which situation is better? Obviously 15 years, 15 years of recurrence, but also biologically, same is true for prostate and breast cancer. It's much, much more likely that the longer, if you have a chemical recurrence, the further that chemical recurrence is from the treatment, the less likely is that you'll die from prostate cancer. Not simply because there's more time since the treatment, because biologically those tumors tend to be less aggressive. Okay, and you can sometimes see patients recur in 10, 15 years that can happen. It's not that often for prostate cancer.
Yes.
My radiologist suggested I've had 45 sessions of radiation. Then he suggested I'm getting hormone therapy, and he suggested to me that I'll probably get it for the next year and a half. The shots bother me. They have a hard time sleeping at night because of makes my hip bones sore in that area there, and I don't have any energy anymore.
Well, this gets back to what I was sort of talking about earlier, is that, and just, keep something in mind. In other words, whatever your concepts are about prostate cancer, you think that this is great or this is great or that great. What I'm trying to say is that probably if you look at the age-related information from autopsy surveys, at age 80, 3/4 of patients who have prostate cancer at autopsy did not know that they had eternal life. So it obviously makes the point that the majority of these tumors, even without treatment, you're going to do okay. It's basically not going to guarantee life. This is yet, and again, one understands why you're getting the medication, but again, to me, just becomes another issue of what I consider to be, if you're the patient, you think about these things. There's a lot of different things that you're put through with this. And, this to me, in other words, it's totally understandable why if you have a higher risk prostate cancer, why they want to get the medication. But, it's not in terms of the quality of life issue again. Okay, so basically what happens is your testosterone levels going down to 0. You have no energy. You can have changes in your blood lipids and blood fats. You can have an increased risk of getting something called metabolic syndrome. You can end up getting diabetes, coronary heart disease because of lipid issues. You can get osteoporosis, all sorts of different things. And also just from a purely subjective point of view, it doesn't feel great, for your testosterone level, which may have been 500 for it to be down to 10. So it's like, so the thing is that what you're describing is not a shock. You can get hot flashes, which can be people feeling hot and cold, but also can be things like emotional lability, for example. I remember several years ago, I had a patient who had metastatic prostate cancer. He was about 85 years old. Every time I came in and looked at him, he started crying. And it wasn't because I said or did anything. It was just simply he had such emotional roller coasters that he just couldn't control things. So it's not easy. It's not easy. And what you're describing is fairly typical. So it's
A year and a half, a long time to take hormone shots.
It depends on your point of view. It depends what you're treating. In other words, I think that here's the realities again. If you're talking about a tumor that has, let's use as an argument, a higher Gleason score, like a Gleason 8, and your PSA was 25 or something, you start in a short PSA doubling time. These are tumors that are basically have a really high chance of relapsing. So the question is that, do you want to give the medication for whether it's 6 months, a year, 2 years, or indefinitely, or do you want to just basically do watchful waiting after that and see what, when and if you recur? So it's not easy. In other words, I think that what I'm trying to tell the audience here is that with many tumors, like for example, we're treating lung cancer, well, you don't have to worry about that. Well, I'm not going to be able to pee. or my lungs are gonna fall out, or I'm gonna have, hot flashes, all this other stuff. It just seems to me that for prostate cancer is that what I'm trying to get across to everybody, and I mean, look, I haven't had prostate cancer as far as I know, people here have, is that it's not a picnic. There are a lot of everyday quality of life things that I'm sort of pointing out, which really get affected by these treatments. And the treatments are, and I don't know the details, but I'm guessing it was a high Gleason score, maybe a high PSA with it. And the reality of it is like, well, basically, do you go through this really psychological and physical discomfort with the hope that the prostate cancer stays away, or do I leave myself open to having an early recurrence? All these points that we're talking about, the point that was well taken here about whether to do something, these are all individualized. There's a lot of different things that you have to go through to figure out. In other words, you have to figure out what you think might be the risk of recurrence, how dangerous the tumor is, what else are we dealing with, how old is the patient, how many other illnesses do they have, and you have to sort of figure out like what the biggest problem is. I mentioned my dad. I mean, on his list of problems, number 15 was prostate cancer. He had a bunch of other stuff. And I was right. I mean, he survived in 4 years after prostate cancer, never bothered him. He ended up dying with, I think, a stroke, actually. Dying of a stroke. So,
So guys, we gotta kind of close up because our time's running out. Yes, sir. Yes.
After hormone therapy and patient went for 2 years.
I'm sorry, after what? Cobalt therapy?
Hormone therapy and radiation.
Okay.
Went for about 2 years, there is no evidence of recurrence.
Yeah.
The testosterone level is 10. Low.
Yeah.
There's some symptoms related to it. Would you recommend giving this patient?
I would. I would. Let me mention something else. Over the age of 70, if you get treated with,
Over the age of 70, if you got treated with probably at least 4 months of hormonal therapy, with basically injections, 4 to 6 months of that, over the age of 70, the chances are 50, 60, 70% that the testosterone level will never be normal. It'll always probably be under 100. It will not be castrate level. Castrate level is near zero. Okay, so what happens is that although these injections don't damage the testicles or anything like